Well, I think everyone should just get tested and find out where they are, regardless of whether they feel like they have a risk or not. But then think about it. If you have personal family history of diabetes or prediabetes, or even obesity, because obesity and diabetes share a common pathophysiology in many cases, and so everyone should get screened, including kids, age 10 at least, 10 and up. We should all be screened, and not just once, but on a fairly regular basis. Depending on your risk factors, that regular basis might be every year. For others, it might be every 3 years. For some people, it's more often if you're kind of teetering on the borderline.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's so good to see you two.
Hi.
Hello.
All right, on the show this week, we're going to be talking about diabetes. But before you click the off button or switch to a different podcast, this is something that affects about 1 in 2 Americans today. And we're also going to be talking about the numbers overseas for those of you listening around the world. But diabetes is a really serious condition. So between diabetes and prediabetes, about half the U.S. population is in that bundle. And of the people who have prediabetes, something like 80% don't know they have it.
Because you don't feel it.
I was pre-diabetic.
Me too.
And I had never been tested for diabetes, and I was pre-diabetic, and all my numbers were horrible. So today is just dedicated to the idea that if it's not you, it's somebody close to you. And
Could be sitting next to you right now.
Andrea.
It's true.
I love it.
But it's true. You could be looking at him right in the face.
Yeah. But we need to know really what it is, how to diagnose it, and what we can do. And the good news is the vast majority of these cases are very treatable. So, Dr. Cooper, let's jump in just with a basic definition. When we say diabetes, it can be a lot of different things, but what do we need to know about the dynamic and also about the very important hormone insulin?
With diabetes, there's various different forms, but each form of diabetes includes elevated glucose levels. Glucose is another word for blood sugar. And so this would be an elevation of blood sugar in ranges that are much higher than the normal range. And there can also be abnormalities of insulin, either too little insulin or too much insulin that's just not working properly. It depends on the type of diabetes and the stage of the diabetes.
And describe again, insulin is a super important hormone that does what?
Insulin is very important because it is a hormone produced by the pancreas, and it informs the rest of the body of our nutritional status, and it helps deliver fuel in the form of glucose to our tissues, including our muscles, our body fat. It has less action in the brain. The brain can actually take up glucose without insulin, but it has some action in the brain. So throughout our body, it relies on insulin in order to get access to glucose, which is the primary fuel.
And if you have elevated blood sugar levels, that can really have a profound impact on the health of all kinds of organs and systems in your body, correct?
That's absolutely true, because elevated blood sugar can be detrimental for our coronary arteries and our heart, our kidneys, our vision, our eyesight, our nerves, and our nervous system. So many things depend on a normal range of glucose, and once it gets to be too high, there can be consequences of that throughout the body.
Okay, so let's jump into type 1 diabetes. There's type 1, there's type 2, and there's prediabetes. I have a good friend with type 1 diabetes. When we go to lunch, As we're sitting there at the restaurant, he takes his blood sugar level and then decides what he's going to have on the menu. And it's just exhausting. I mean, looking from the outside at
Yeah.
how much people have to do to manage type 1 diabetes. What exactly is it, Dr. Cooper?
Yeah, type 1 is really very different from type 2. And it is unfortunate that they get clumped into the same category because type 1 is far less common, but the people with type 1 always feel sort of left out with the messaging that's always geared towards people with type 2, and it really doesn't apply that much to them. So the antibody production that attacks the pancreas, what ends up happening is it destroys the pancreas's ability to produce insulin. And those patients end up with just a complete insulin deficit. And it happens kind of abruptly. I mean, there is a little bit of a gradual onset, but it's quite fast going from the deterioration of the pancreatic insulin production to like no insulin production. And when that happens, the blood sugar levels go very high because insulin is such an important hormone that delivers this fuel to our tissues to use for energy. So if we don't have insulin, the glucose, which is the fuel, builds up in the bloodstream at very high levels. And that's very dangerous. It ends up normally with a hospitalization, starting on insulin. And unfortunately, it's at a young age typically. And so in childhood, kids have to deal with this. And all of a sudden, they have a disease that requires them monitoring everything. And it's tough at a young age. There are some cases where the onset is later in life, and that's less common, but it can be later in life. And so it's really due to these antibodies. And one thing to kind of mention is the antibody triggering of the antibodies often is preceded by a virus. So the virus could be some type of virus that a person gets, and that stimulates production of antibodies in the system to fight the virus. And that's where the immune system starts to release these other antibodies that are capable of attacking the pancreas. And so often after viruses, including the COVID virus, this can happen.
I've heard about like a diabetic coma. Is this something that happens for type 1, type 2? Which one comes from that?
Well, it would be more common in a type 1 patient because it would be due to too much insulin being administered. It's called exogenously, meaning your body's not producing the insulin, you're taking insulin as a medication, and you overestimate the amount of insulin that you need. And so then your glucose goes into the tissues and leaves the bloodstream and ends up in a critically low range, which can push you into a coma, a diabetic coma. So that would be much more common in type 1 patients, although it could happen in a type 2 patient too that was taking insulin and mixed, especially insulin mixed with other medications, where they could get into a low glucose situation. But it would be far more common in type 1. And that's why a lot of type 1 patients use insulin pumps. And the insulin pumps are fantastic because the technology has come so far that they really do a good job typically of managing the glucose to keep it out of those low ranges and out of the high ranges. And so it's left to the machine and the intelligence in the machine to deliver the appropriate amount of insulin based on the glucose that's being sensed by a continuous glucose meter that's connected to the pump. And so this gives them a lot more precise control of the glucose and better management and easier management because it's like not the old-fashioned way of having to poke yourself and give yourself a certain amount of insulin and then eat a certain amount and then poke yourself and all day long. I think things have come a long way to help prevent that diabetic coma and prevent extreme hypoglycemia.
Wow. So the takeaway for type 1 diabetes is that it is not reversible and that you do have to inject insulin for your life, right?
That's right. That's absolutely right.
Now we're on to type 2, which is the more common kind that is really at epidemic levels here in America and probably in the world.
That's right. Yes. And type 2, now we keep in mind, type 2 in particular has a very strong genetic predisposition involved. So if you have family history of type 2 diabetes, your chances of developing type 2 diabetes are much higher than
You're
someone without.
doomed.
Well, not necessarily doomed.
But like
Um,
typically, like I had a grandparent that had
mhm.
diabetes, so maybe that
Yeah.
explains my pre-diabetes.
Yeah, I mean, it could. It really carries out through the generations. And what they found is a lot of these things amplify with each generation. So it actually, the tendency gets worse as each generation comes through. And so, but the nice thing about type 2 diabetes is there's a prodrome, meaning there's a precursor condition called prediabetes. And so, if we can catch things in the prediabetes stage and prevent this condition from progressing all the way to diabetes, then that's great. That can be wonderful because it's much more reversible if it's in the prediabetes stage. So, type 2 diabetes, there's a lot of different, it's genetically triggered normally, but we do have some environmental kind of factors that could really promote it as well. And unfortunately, it goes back to these endocrine disrupting chemicals in our environment, which we've talked about before, the plastics and the off gassing of things and the PFAS, all of these different chemicals in our environment that can participate in triggering. There's certain medications that can push people towards it, like steroid medications, psych meds, sleeping meds. There's just a lot of them that could actually promote the progression to prediabetes or diabetes. Then also our stress levels, our sleep deficits. There's just so many aspects in our environment that could feed into the triggering of prediabetes and diabetes in someone who has the genetics, basically.
Okay, so let's define how diabetes is diagnosed because it's really based on numbers of certain things in your body, right?
Yes, it is. And it's good to think of it as a continuum. So if we start from the beginning, before you get to type 2 diabetes, because it takes years and years to get to type 2 diabetes, you go through these other precursor stages first. And so the most common, this is not always the case, but I'll just tell you about the most common way that this all progresses. But keep in mind, there are outliers, kind of a good percent of outliers where it doesn't always follow this. And what bothers me is that in kind of the messaging that we get, it sounds like everybody follows this course. And that's just not true. There's some individual ways that people progress down into the diabetes mode. But the typical would be starting with a problem with insulin. So you would start out, and this is even before prediabetes. So you would start out with normal glucose level. So if someone checked your fasting glucose or your average glucoses, they would say, oh, you're normal. But if they look closer, they might see that your insulin levels are inappropriately elevated. And that could be your fasting insulin, or it could be your insulin in response to eating. So this condition would be called either hyperinsulinism if it was something where it was like an inappropriate increase after eating, or it could be insulin resistance when the insulin is having to go up really high to try to pull glucose down that's sort of getting close to the top of the normal range. But in any case, these insulin elevations are often the first thing that starts to happen. And then once that kind of has set in, then after a while, the body becomes resistant to this insulin, more and more resistance to the
Hmm.
insulin. And when we say that, we're talking about mostly the muscle cells that are resistant and maybe the liver cells that are resistant to the insulin signal. So then the muscles can't really take up the glucose because remember, the insulin is geared to deliver that glucose to our cells, to our tissues to use for energy. And if our muscle cells are resistant to it and our tissues resistant to it, it won't respond to that insulin signal. It won't take up that glucose. Then that glucose starts to build up in our bloodstream. That's where then your lab work will show, oh, you're above the normal range. You're in pre-diabetes. So that's kind of how the thing starts. And, from prediabetes, the insulin levels start to increase more and more to try to push that glucose into the cells to use for energy. And after a while, because of that resistance, the glucose just builds up more and more and more. And often what happens is the pancreas that produces the insulin gets kind of tired out from producing this insulin, or the cells they start failing basically to keep up with the amount that the insulin has to go up to keep your glucose normal, because it's fighting that resistance. And that's where it flips then into full-blown type 2 diabetes.
So a patient comes to your office, and how does he or she know that that there's prediabetes? Like how do you tell them?
Well, one thing to keep in mind, normally people don't feel anything
Yeah,
when they have
because
prediabetes. Yeah. So it's one of those that a lot
it's
of,
not like, oh, I feel weird. My blood feels strange.
yeah,
Because I mean, I know that for me, I didn't feel anything.
right. Well, and the thing is that until you get to full-blown diabetes, you may not have any symptoms at all. Even in
Right.
diabetes, people don't recognize some of the symptoms, typical symptoms. But in prediabetes, it's really needed to do the screening. I mean, we really need to step up our screening of people because it is so silent. It is so silent. And so you really rely on just the screening test to tell whether you're in the prediabetes range or not.
And what is that? Blood sugar, insulin? What are the numbers?
Well, the typical screening for prediabetes and diabetes, it's fasting glucose and HbA1c. HbA1c is hemoglobin A1c, which usually in our country, it's reported as a percentage. Around the world, it's reported differently in some areas, but it reflects the average glucose over the last few months. And it's just on a single blood test, and they can tell that because it's tied to our hemoglobin, which has like a 3-month lifespan. So those two markers are the standard. And then we can also look at a 2-hour after eating glucose level. That's also done sometimes. But the typical would be basically the fasting glucose and the HbA1c. And based on those numbers, it will classify someone as normal, prediabetes, or full-blown diabetes. So the normal in the US, I'll tell you about the US. What's interesting is I did a little research, since we have so many listeners from around the world. I wanted to make sure that we're considering outside of the US. But it turns out that throughout the world, there's an agreement on what constitutes diabetes, type 2 diabetes. The diabetes cutoffs are the same throughout the world. So for diabetes, if your fasting glucose is 126 or higher, that's diabetes. That's around the world. And if your HbA1c is 6.5 and higher, that's diabetes. So there seems to be general agreement throughout the world on that. Where there's some differences is what constitutes prediabetes versus normal glucose. So in the US, normal glucose is below 100 fasting. But if you're at 100 to 125, now you're in prediabetes in the US. And for the HbA1c in the US, below 5.7 is normal, but 5.7 to 6.4 is prediabetes. But as I was looking around the world, there are some higher cutoffs for the fasting glucose. In Japan and China, they're higher, and I believe Australia. So you'd want to look at your local area, but it might be good to think of, is there really a difference between 100 versus 99? I mean, when we're really logically thinking about it, we don't see a huge difference. It's more of a scale. So you don't want to think of it as black and white. If I'm 99, I'm perfect. And if I'm 100, I'm prediabetes.
So, Dr. Cooper, would there be some other measurable things that could indicate prediabetes or diabetes, things like blood pressure or excess weight or some other factors, or is it strictly determined by those metrics?
For diagnostic purposes, it's strictly those metrics. But that doesn't mean that certain groups aren't at higher risk. Definitely, we see an increase in the rate of prediabetes and type 2 diabetes in people that are at a higher body weight. And then we also see it in conjunction with the metabolic syndrome, which affects blood pressure and can also show some abnormal cholesterol profile indicators involving triglycerides and the HDL cholesterol. So you could see this as a clustering with other conditions, but for the actual diagnosis, it's really reliant on just the glucose and the HbA1c. And if you have, say, you have a normal fasting glucose, but an elevated HbA1c, the criteria is that if the same one, if you have the elevated marker, if it's elevated twice in a row, that's good enough to diagnose.
That's interesting. So, what would be a typical treatment plan for someone in prediabetes?
Well, I think that again, it goes back to everything in medicine. Everything should be individualized. But one thing to consider too, which is alarming, is the statistics are showing that up to 20%, 25% of kids, I think I read 18 to 25% of adolescents are in the prediabetes range. So we have to think of with our treatment also, what about adolescents? There's going to be a different treatment for young people. And there's another thing to think about that we were discussing before, that it's now considered that 80% of people with prediabetes are not diagnosed.
They don't even know it.
They don't even know it. But
Wow.
about that, we've made some progress because 10 years ago, that was 90%. So there is some progress, and some of that's because some of the screening guidelines have loosened up of who's screened. It's not just based on people because their weight's high that we're screening. We're recommending screening now age 35 and over for everyone, regardless. But it's probably still not good enough, the screening, and the screening recommendations or the screening habits aren't good enough. But getting back to your question of how to treat it, based on that glucose and insulin level and where you are on that spectrum, are you on the insulin resistance, which is a precursor to the prediabetes, or are you in prediabetes, or are you in full-blown diabetes? There's going to be different treatment. And as you mentioned, Mark, do you have other conditions? Do you have elevated blood pressure? Do you have cholesterol problems? So based on all of that, you really want to look at the whole picture, because we have various lifestyle strategies, but then we have also pharmacology. And the pharmacology is best if it's applied based on the person's whole health, because these tools can produce benefits in many different areas, and you want to target it to that person's problems, basically. And so one person may do better on one type of path versus another person on another. But the goal of the treatment is to bring the glucose levels back down to normal and to bring the insulin levels back down to normal if they're elevated. So I think that's the main part of the treatment. And in terms of lifestyle, it's really focused on all those things that we talked about that could trigger the prediabetes and the diabetes. So that starts with our sleep, making sure we're getting adequate sleep, screening for sleep apnea, making sure that's taken care of if it's there, because these all feed in and amplify. Looking at all the medications a person's taking, are there any that are promoting high glucose levels? Can they be changed? Because there are quite a few meds that could aggravate prediabetes and push someone towards diabetes. And then we want to look at the nutrition patterns. Is the person eating regularly and consistently getting all the food groups, including complex carbohydrates, which are shown to really be beneficial? So that's whole grains, beans, legumes, all your fruits and vegetables and all of that, enough protein sources, your fats, mostly coming from plant fats, because animal fats have been shown to potentially increase risk of diabetes. So there's all kinds of things nutritionally that are beneficial to look at. The microbiome is beneficial, and we've talked about that before. Then when it comes to exercise, physical activity is helpful, because what's really great about exercise with diabetes and prediabetes is that when you exercise, your muscles have an extra channel that opens to suck up that glucose, to take that glucose in, that's not reliant on insulin. So that's fantastic for people with insulin resistance, because then if you've got an elevated glucose, when you exercise, your muscles can still take up that glucose through an alternate pathway. And that helps reduce the blood glucose levels. And so exercise is great too. And so those are the primary things to think about.
So it's not from just eating candy.
No, I mean, there are research studies that are done where they force feed animals and things like that, like crazy things that are not like massive amounts of high fructose corn syrup or massive amounts of saturated fat, and they can push them into diabetes doing that. But in real life, people are not doing that. It may be one thing to keep in mind, though, is that when you have a metabolic dysfunction that's kind of pulling you towards prediabetes and diabetes, you probably are craving sugar more, but that sugar craving is a symptom. It's not really the cause of the issue because if you can't get the fuel into your tissues because of the insulin resistance, your tissues will feel starved of glucose, starved of sugar. So that will kind of lead to sugar cravings as well.
Oh,
So
that's interesting.
I
yeah.
think that's exactly what I had when I first came to see you, Dr. Cooper. I had
Mhm.
an inappropriate insulin response. So after I ate, my insulin spiked, and that caused my blood sugar to crash. And so
Yes.
then I was craving sweets. And so I was overeating and eating too many sweets because I was all out of
Yeah.
whack. Yeah.
Well, not only that, then you're on a roller coaster because then your blood
Mhm.
sugar, and it's true, your insulin, it was called hyperinsulinism because it was going up even though your blood sugar wasn't high. It's like you ate. A lot of people, when they eat, they think that the insulin goes up because their blood sugar's too high. That's a popular kind of thought that I've heard out there. So a lot of people with these glucose monitors are trying to like keep their glucose from going up when they eat. But it's normal for our glucose to go up when we eat. But in your
Isn't it?
case,
Yeah, that's what it's supposed to
that's
do,
what it's
right?
supposed to do, yeah. But in your case, Mark, it went up, but only a little bit, but then your insulin went through the roof. And so because of that, the insulin carried the glucose into your cells to use for energy, and that caused your blood glucose to actually drop too low.
Hmm.
And then an hour after you ate, you were like starving and needing to eat sugar because
I was
you need
hangry.
yeah, you needed to. Yeah.
Right.
So that
Um,
yeah.
Yeah, that's so interesting.
Yeah.
Getting back to, I'm sure people are wondering what types of drugs that are typically prescribed, and I know that it's individualized. But can you
Sure.
give us an idea? I mean, metformin is one, but what's the range of pharmacology to treat diabetes and prediabetes?
Yeah, and metformin's like a mainstay. Metformin is the oldest drug. When I was in training is when it came out in the US, and it was already out in Europe, I believe. So it's been around for decades. But it is a very useful medication and it improves the insulin resistance at the liver and improves the ability of the liver to release glucose at a very even pace that's regulated so that the glucose isn't just dumped out all the time. So it particularly works well for our fasting metabolism, the metformin, because that's when we rely on glucose from our liver. But for the glucose increases that happen after eating, the medications that are the most effective are going to be the GLP-1 group of meds and the GLP-1 GIP, so that dual agonist as well. So those are used often to control the what's called the prandial phase, which is the post-eating phase of glucose and insulin response. So often people need that combination of something to treat the fasting situation, something to treat the after eating increases that happen with glucose and insulin levels. And so that would be like the mainstay would be taking meds from those two groups to try to help control the situation. But there can be other things too involved. And so it's not always that straightforward.
Let's talk about, can we eliminate type 2 diabetes in our lifetimes or in a person's lifetime? Like, can you cure it with metformin? Can you get rid of it? Or are you a metformin person for the rest of your life?
There's different opinions on all of this, but from my clinical experience and from things that how the pathophysiology is with prediabetes and diabetes, if you catch this condition before that beta cell failure, when the beta cells kind of fade out in the pancreas, so in the prediabetes or the insulin resistant stage, most often that is reversible in my experience, but it depends. It really depends because it can be very stubborn and tenacious. And once it gets to the full-blown diabetes range, we are better off now with the newer medications because, believe it or not, the GLP-1s, they stimulate the growth of brand new beta cells in the pancreas. And so if you have beta cell failure, you still have a chance of rekindling your beta cell production with those new medications. Not always, and not if it's like long-term and kind of really extreme, but there are cases where even in the full-blown type 2 diabetes, that can be reversed. And it requires a comprehensive whole person kind of treatment strategy over many years. But you can potentially get to the place where you're much less reliant on medication for that. But I do think that the best time to treat things is in the insulin resistance phase and the prediabetes to get after it there because it is so much more reversible at that stage. It's just much more reversible. But most likely, I mean, these are due to genetic predisposition. We live in an environment that's very triggering. So most likely people will need to take some form of medication, probably a lot less than they did initially to try to get control of the situation, but some form of it over a long period of time.
Yeah, and I think we've talked about this in the past, that we shouldn't see medication as a failure because the fact that these conditions can be regulated with meds to a level that's absolutely optimal and the effect that has. I mean, we just went through my labs a couple of days ago and we were starting to reduce my blood pressure medicine because my blood pressure is naturally lowering because the entire metabolic system is getting fixed.
That's true.
I look at myself as a miracle of science. I am a product of science and pharmacology. I'm happy about it. I mean, I have a hard time sometimes understanding why people are like, oh, I don't want to take any medicine. I'm just like, well, if it makes you better and makes your body happy, like, go with it. Be happy and healthy and I don't know. I mean, yes, it would be great to be natural and be pure and be wonderful like that way. But if science can make you better, isn't that amazing? Isn't science amazing? That's why, fat science. I'm fat. I'm still sort of fat, and I'm a miracle of science.
Well, it's like we don't want to go back to the days of having to take pig duodenal extract.
No, that really kind of freaked me out a little when you were talking about that. But I still probably would have taken it if they said, "Oh, this is going to work." I'd be like, "All right, I'll try it."
Well, the metabolic system is too important to neglect, and too important.
It does everything. We're learning that.
Yeah, because as we always say, it's a complex system in itself, but it affects every other system in the body.
Yeah.
And that's why anything we do that improves our metabolic function has a lot of carry-on benefits. And so even if you look at, say, metformin, they're seeing that metformin reduces the risk of atrial fibrillation significantly. Mm-hmm. And so that is another unexpected benefit. It also reduces the chance of post-COVID diabetes progression and things like that. And it reduces the risk of that long COVID condition. So metformin has a lot of benefits too, and even cancer prevention they're finding with metformin. So, and then you look at the GLP-1s and there's so much benefit to the kidneys, the cardiovascular system. They're now looking at dementia risk. So it is true. What I look at is how healthy is this person, regardless of what they're taking. We don't think about that. Just look at their whole profile and where they are. How healthy is that person? Right. And how does that compare to how they were previously? Because when you have someone with a lot of risks, you have to kind of look at their trajectory. Where are they going? So without treatment, 5 years from now, where will you be? With treatment, now you have completely changed that trajectory to a much healthier pathway. And you've kind of skirted the dangers of a disease like diabetes that could lead to blindness, amputations, heart attacks.
That is not a happy person.
Yeah, and kidney failure.
Kidney failure.
Any one of these catastrophic outcomes
disaster
can ruin your life.
Yes.
Yeah.
Like literally kill you.
Yeah. So we're lucky.
Which is not happy. That's not a happy place to be, the death thing.
No.
Well, for most people.
No, so we're really lucky. We live in a time where the treatment options are very good, and our knowledge is advanced enough to know the lifestyle factors that play a role as well.
Right. So get tested.
I like that, Andrea. And Dr. Cooper, as we wrap things up, I'd love for you to talk to that 50% of the population that may be in the risk group and doesn't know it. What should they do? How should they proceed?
Well, I think everyone should just get tested and find out where they are, regardless of whether they feel like they have a risk or not. But then think about it. If you have personal family history of diabetes or prediabetes, or even obesity, because obesity and diabetes share a common pathophysiology in many cases. And so if you have genetic risk for one, it sometimes will definitely increase your risk for the other. So if you have that family history, or if you've personally had something like gestational diabetes, which we didn't talk about, but gestational diabetes increases your risk for future diabetes. Or if you're a child born to a mother who had gestational diabetes, that also increases your risk. If you're on certain medications in that psych category, or if you're on steroids, those would just be heightened reasons to get screened. But I just feel that everyone should get screened, including kids, age 10 at least, 10 and up. We should all be screened, and not just once, but on a fairly regular basis. Depending on your risk factors, that regular basis might be every year. For others, it might be every 3 years. For some people, it's more often if you're kind of teetering on the borderline.
And these aren't super expensive tests. These are simple blood tests. And I just think that the benefits so far outweigh the risks of not getting tested. And I had a really good family doc, but he never tested me for this. And I had a lot of other conditions, high blood pressure, high cholesterol, all that stuff. And when I first started seeing you, Dr. Cooper, that was the first thing that we did, and saw that it was a serious problem. So, as Andrea says, get tested, because one of the missions of this podcast really is to raise awareness about metabolic syndrome and also the diabetes epidemic in our country and around the world. So, well, this has been a really enlightening conversation. Anything final thoughts from either of you?
It's the same thing. Get tested, know your numbers, and really think about what to do, and talk to your doctor about it, because like Mark, I had a great doctor too. And it was like, oh, we'll just, we'll look at it, we'll see how it goes. And it didn't go that well.
Yeah. And it's important, because it's also important just to intervene as early as possible, because that's when it's the most reversible.
And, Dr. Cooper, every time we have labs about, every 3 or 4 months, really extensive labs. And I'm just blown away at how optimal all these numbers are. I'm thrilled. I'm just giddy that when we look at cholesterol and blood pressure and all the things that were a real problem for me not that long ago, that you talked about trajectory. And, I just turned 60 last year. So I'm looking at the next 20 years and I'm thinking, I just want a really high quality of life for the next 20 or 30 years, hopefully, fingers crossed.
Yeah, we all want to age well, that's for sure.
Yeah. Well, this has been great. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.